Good afternoon, everyone. My name is Mark Hughes. I co-chair the Hospital Ethics Committee. Welcome to our May installment of Ethics for Lunch. So this is a monthly series. A lot of you may have attended previous ones. So co-sponsored by both the Ethics Committee and the Berman Institute of Bioethics. So the handout gives you a little bit of information about the Ethics Committee and our consult service and the members on the committee. So if you have any questions about any of that, feel free to contact us. We're going to have one more session after this in June, and then take a couple of months off for the summer. But we'll look forward to seeing you for the next one, and then restart things in September. So for today, we have a distinguished panel. We're going to get to hear from all of them. Our moderator is Dr. Michael Clark. He is an associate professor in the Department of Psychiatry, and I'll have him take things over.
Thanks, Mark. Thanks, everybody, for coming. As you heard, my name is Michael Clark. I'm the Vice Chair of Clinical Affairs for Psychiatry, but more importantly for today, I'm the Director of the Chronic Pain Treatment Program on Myers 6. Just out of curiosity, how many people have heard of that program? Okay, so a good number. So I thought we would discuss a typical case, but I first want to introduce the members of my team. This is not the entire team, but it's a good representative sample. As they say, it does take a village. Mary, why don't you start? And then people can just, you have to push the button in the middle to make your microphone green, and they really want you to talk into the microphone.
Oh, okay. You have to hold the whole time? No.
No, just push it, and it should go green.
Okay. So my name is Mary Cooper. I'm the nurse manager for the Pain Treatment Center. I've been with the program actually since 1976, so I've seen it evolve and grow to what it's become today.
Hi, I'm Maggie Pruitt. I'm a physical therapist, and I work with pretty much all the patients in the pain treatment program, and I've been here for about 4 years.
Hi, my name is Tess Spence. I'm the occupational therapist, and I've been with the pain treatment program for maybe 6 months.
Hi, my name is Tracy Haley. I'm the coordinator for one of our outpatient programs, our chronic pain partial hospitalization program that is an adjunct to the inpatient service. So once they're ready to step down to outpatient treatment, they come my way. And I've been with the pain service for about 17 years.
Hello, my name is Jim Everett. I'm the NC3, or for those of you who don't know what that is, the senior clinical nurse on the pain service. I'm in charge of the inpatient patient population and of being educated nurses on how to care for our inpatients. Also do biofeedback with our patients and kind of help with rounds each day as it communicate the changes and things that we do with our patients to the nursing staff. And I'm actually going into my 30th year in the pain service.
Good afternoon. My name is James Cole, and I'm a senior clinical social worker in the Department of Psychiatry. I've been working on Myers 6 on the pain service since June 2004, and I work with both the patients on the inpatient service and also in the day hospital program and their families, and provide group therapy and also ensure that they have a sound aftercare plan.
Great, so you can see that this is an experienced group. And as you heard earlier, this was a program that actually started in neurosurgery by Donlin Long, the former chairman of that department, and then moved into the Department of Psychiatry in the 1980s when the Meyer building opened. And our department was looking for subspecialty programs that we thought would be appropriate to continue this kind of multidisciplinary approach. So it's been there ever since. One thing you should know is that we're probably the second program that started in the United States, and we are the last, because while there was a boom in this field back in the 80s and 90s, almost every academic medical center had one. They had a similar format that I'll describe to you in a little bit. And even for-profit hospital chains got into this business space. As time progressed, almost all these programs except us and arguably a program in the VA system have been driven out of business by scrutiny of the third-party payers and to some degree the inflexibility of the programs to accommodate the changing landscape of chronic pain management and also insurance coverage of these services. So the traditional program was one in which it was hardwired. Patients would be initially screened in an outpatient appointment by multiple disciplines like you see sitting here. Ultimately, what determined admission to many of those programs was a psychologist doing an MMPI screening questionnaire and then interpreting that profile as appropriate or inappropriate for this type of program. And so essentially what got ruled out was almost anybody who was going to be difficult or complex and challenging. People with major mental illness, people with addiction, people with personality disorders, people with psychosomatic complaints, people with high levels of emotional distress. And in many respects, they were cherry picking for patients who were highly motivated, relatively straightforward, willing to come off of all of the medicines that they were taking, and then engage in cognitive behavioral psychotherapy in group-based settings, and engage in active physical therapy to begin a process of physical restoration. The length of stay was also hardwired at about 30 days, give or take, depending on the weekends. And many programs would admit an entire cohort of patients and then discharge that cohort, regardless of where they were in the process. And you can see why the insurance companies then started to say, hey, wait a second, this seems really cookie cutter and it seems really expensive and you won't take any of the really tough cases. And so what are we going to do? So they basically stopped paying for it, and many programs transitioned to partial hospitalization or intensive outpatient settings. And many of those still survive today, but not nearly as many as they were. We have never had a screening process like that. And people ask me, what are the criteria for admission? And it basically boils down to the patient has to want to come. They don't have to know why or what they want to do or how they're going to do it, but they just have to say, I need help and I'll be admitted. They have to be medically stable enough to participate in the program because it is a program of rehabilitation after all. And somebody has to pay the bill because the hospital wants that to happen occasionally. So, so we have pretty much taken all comers. If you name a chronic pain syndrome, we've probably seen it. If you name a psychiatric syndrome, we've seen it in that context, and many rare conditions from neurology and oncology, and again, name the discipline. We like that. It turns out when we look at our data for outcomes that we actually do better with more complex cases, which actually shouldn't be a surprise because less intensive cases can be managed in less intensive settings and in other places. And so we are serving what we think is the mission of Hopkins, the kind of tip of the iceberg, complicated, refractory, very disabled cases. Our prior chairman, Ray DiPaolo, used to refer to this as the miracle service. Because because we would frequently take a person who everybody thought was going to be a disaster and not benefit, and who had been in a wheelchair for 10 years and was on all kinds of medicines, and what was the point, really? And yet, more often than not, that person would have a successful outcome, in some cases be pain-free, walk out under their own power with no assistive device, and go back to a productive life. We've had people go back to school, we've had people go back to quite demanding jobs. So it really is an important mission and an important service. And so at the same time, it presents many ethical related conundrums and challenges for us in taking care of these patients. And I hope to talk about that a little bit, but to have others talk about what they encounter, because it's in some ways discipline specific, but also to get a conversation going with all of you. I'll just read you the case that you have in front. Just to give everybody a little bit of a flavor for what we see. If as I'm reading this you say, hey, that's me, or that's my friend, it isn't. You know that chronic pain affects about 1/3 of the United States. The types of patients that we see obviously are the minority of those cases, but all too common. And our waiting list for this service is months and months long. So this particular case I want you to think about, 47-year-old Caucasian woman admitted to us with the chief complaint of disabling chronic low back and leg pain. It's been refractory to a variety of treatments and is accompanied by depression with suicidal ideation. She has a 10-year history of problems associated with her back. They began after a fall at work while operating machinery and attempting to reposition a load of boxes. She experienced localized pain in her low back immediately, a little bit worse on the right than left. Was subsequently seen that day in an urgent care setting, given the diagnosis of musculoskeletal strain, and x-rays were negative of her spine. She was sent home and told to take a few days off from work, NSAIDs and Tylenol, and so she did. Goes back to work, notes that over a protracted period of time her pain begins to return and becomes increased in severity and duration, begins to interfere more and radiate down her right leg with some associated numbness. She starts to miss work, starts to see her doctor more frequently, gets referred to multiple consultants, has seen a physical therapist, a neurologist, and an orthopedic surgeon. At that point, an MRI is done, which shows a small herniation of her L5-S1 disc with equivocal compression of the right nerve root, and subsequently is referred for a discectomy. Afterwards, she has some improvement, and her pain is better. She's able to go back to work. She's not 100%, and over time, she has some brief exacerbations of her old friend. But then, again, over the ensuing years now, longer duration episodes of pain, more severe pain, and more radiation down into the right leg. She's prescribed a variety of medications, NSAIDs, tramadol, eventually oxycodone. The doses are gradually increased. She gets more workup, an EMG nerve conduction velocity study that shows a right-sided radiculopathy, some foraminal narrowing and spinal stenosis on a repeat MRI. She really can't work full-time at this point, and subsequently comes to a laminectomy. Doesn't really get any better, and then a few years go by, and now it's recommended that perhaps her spine is unstable and she should have a lumbar fusion surgery, which was done. She's now admitted to us after having gone through all of this, still having pain on even higher doses and even even more numbers of medications. And it's not unusual for us to see a case like this, accompanied by this overwhelming sense of increasing demoralization, frank major depressions in many of our patients, and a sense that their future is hopeless, and perhaps the only option at this point is suicide, or in some of the cases we've seen physician-assisted suicide. And we've had people stop here on their way to Europe or Oregon, thinking that that would be kind of the next stop if it didn't work here. So the other thing that complicates many of our cases, this case included, is that there's a fourth party involved. Besides her insurance company, there's a workman's comp carrier. And those take various forms, as you probably know. Some are more benign than others, but essentially the challenge is laid down: prove to us that you're disabled and can't work, or we won't pay you. And even if we do pay you, we will constantly ask you to reprove that you're disabled, and we will frequently stop your financial income just to stress the system, and because we don't think that you really are unable to work. So let me just take a quick break and ask, are there any questions about the case or the types of patients that we see? Okay, hearing none. Some of the things that we encounter in the services really revolve around what's a patient. Because in this world of modern medicine, you hear a lot about customer service, and that the customer is always right, and the measure of that is patient satisfaction. So how many people think that the patients that come to us are happy about being admitted? Okay, your arms are paralyzed. And how many people think that our patients are really happy about being detoxed from all of their medications? Right, more paralysis. It is not uncommon for us to see people on 1,000 milligrams of oxycodone or its equivalent a day. It is not uncommon for us to see people on one or more opioids, a benzodiazepine, a muscle relaxant, a sleeping pill, a stimulant, and probably a few other things. And it's not that we are against medications, it's that we're against medications that don't work and cause other problems and actually make the person worse in so many different ways. But yet, people who are coming through the door have been trained by the healthcare system that they have a right to things, and they want what they want, and they want you to give it to them. And if you don't give it to them, then your patient satisfaction scores go down. Or they file complaints against you with any number of agencies. So a number of years ago, Mary came to me and said, our patient satisfaction is terrible. And I said, yes, I know that. And you know, she was very worried about that, as she should be. And we went through an entire process of focus groups and meeting with the patients one-on-one to try to figure out how can we make their experience better. How could we include more people from their support system? How could we help them understand what we were doing and why? And we saw what we thought were trends upward in our patient satisfaction, only to see them slip away. And ultimately, we met with the woman that headed patient satisfaction. Yeah, Becky Zuccarelli. And she said, I'm here to help you. And I said, that's great. Let me tell you about the program and what we do. And she listened very carefully. And at the end, she looked at me and she said, I can't see that these people are ever going to be satisfied. I said, it's a challenge. They're satisfied 6 or 9 months later when things have gone well and have their life back, but not at discharge or during their hospital stay. And she said, how about if we just take you out of the survey? And so, and along that line, she said, they will take the eating disorder service out too, because they're not very satisfied either, and now I understand why. And in one fell swoop, the department's patient satisfaction rating went up into the green zone. So it does tell you that there are issues that you've got to think about and challenges that you have. The conversion to being a patient is really one that is not meant to coerce people, although that might be what some of you are thinking. It's really to ask people to make a shift in paradigm. People come to us essentially in a palliative care mode. They're seeking comfort. They'd like to be fixed, but they've kind of given up on that. They're seeking comfort. They just don't want to suffer anymore, and they want you to make them comfortable and live a relatively passive life. And our message, which is one that I believe is optimistic and based in hope, is, look, you can make some changes here, and we will help you make them, and actually have an opportunity for a more successful and satisfying life. But it does require your participation. And that becomes the sticking point, is how do we engage those folks to do that? Mary, I might ask you if you would kind of give your perspective, having directed this program for a long time.
I think essentially, just to continue a little bit on what Michael was saying, this is a group of people that really had a career before they came, and that career was to find relief, which they didn't get. And they got into major problems with medicine, to the point where their life, their family, everything that you and I take for granted has been interfered with. And so they have been totally dependent on others. And it's our job to turn that situation around, convince them that they have the opportunity and they have the ability to depend on the tools that we give them in order to feel better. And so those tools are things that the nursing staff, social work, PT, OT, teach them every day. And so you might want to just say a couple words about the difficulties you find convincing people that they really can do this, and they do. But all the while they're screaming in your face or have their fist up, that they're totally inebriated and they're a different person than what they eventually become.
Yeah, Meg.
Hi there. So from a physical therapy perspective, there's definitely a different approach that we need to take with this particular patient population. You know, a lot of times I'm Mary Smith with back pain. I've had back pain for 10 years. That's who I am. That's me. I'm with back pain. So trying to transition the patient from not being a person and identifying themselves with back pain, but identifying themselves as, you know, a human and a wife or a grandmother, or so shifting the focus away from the role of the patient has been a really important focus in PT. So that being said, we've taken a very active approach where the patient's required to be an active participant in their physical therapy programs. So we rarely do, like, no one's going to lay on a hot pack or get ultrasound. It feels really nice. That doesn't do the patient a service in this program. It has its purpose elsewhere, but not here. So having them transition to where they can identify that they can walk for 2 minutes. Maybe I can do 3 minutes next time. And then all of a sudden, a few weeks go by and then all of a sudden they're walking 10, 15 minutes and they don't even kind of mention their pain at all anymore. So that's kind of the fun part for me, is to address a lot of times they have a fear of an activity, and so it's the fear that drives them to stay in a chair. They don't want to get out of bed, because they're fearful that activity will cause their pain. So if we can address the behavior and the fear in a way to expose them to these little bits of activities at a time, then that's how they can really make the functional progress. So.
Tess, how's OT fit into this mix?
So piggyback off of what Maggie was saying, we really focus on the patient's function and on their roles outside of patient and pain. Our role is to identify the things that they haven't been doing because they're fearful that if they engage in cooking or taking a shower or getting dressed or getting outside of their house or going grocery shopping, any of those things, that they will be in extreme pain afterwards. So a lot of what we do is identify strategies to engage in those activities and maybe do the activity a little bit differently. One thing that I've noticed a lot with pain patients or patients that have pain in this program is that they either avoid the activity completely because they're fearful that they'll have pain, or on days when they feel good, they engage in tons of activity and then they have multiple days where they feel absolutely terrible. So helping them to find somewhere in between, I've seen has been really, really helpful for them. And then actually engaging in the activity. So they avoid it for so long. They used to be the cook in the house. They don't do it anymore. Their significant other is helping them with their lower body dressing. All of those things, we kind of help them do it and at a slower rate. So maybe the first time we cook something, we do it from a bag, like cookies, something really simple. And then we increase their activity level so that they actually cook a full meal. So that they feel like when they go home, they can not only care for themselves, but maybe other people in their lives as well. The focus is on increasing their independence in everyday life. Sometimes we're able to do that through activities that they find fun and meaningful, which makes my job really fun. So maybe they haven't been able to go shopping because they've had too much pain, so I get to take them, to the gift shop. Or they used to garden and they don't do that anymore. So we identify different strategies to re-engage in that activity and then actually do it, which is the fun part, and also gives them the confidence so that they feel when they do leave, they are capable of doing these activities.
Great. Tracy, you want to talk a little bit about the day hospital fits into that skill development?
So the patients that are coming to my outpatient program have already been through our inpatient service. It's very rare that we ever get a patient that's directly admitted to our outpatient program. So they've already been through educational groups. They've had the pace and the structure and the setup from the inpatient service. So they're moving through their day. Although they're still being taken care of, at the same time they're going to PT and OT, but they are not caring for themselves. So when they transition from the inpatient program to my outpatient program, what they're going to work on is caring for themselves again. They're going to work on how to get up and get out and moving in the world again. They stay outside the hospital, but they come in at 8 a.m. They go through a series of groups and classes and still continue with PT and OT as an outpatient. But they're trying to see themselves as a person again, so they're moving from that point from patient to person. And they're really engaging in all the daily activities you and I would, and they really see it as a work day. They're finished at 4 o'clock. They leave for the evening and are responsible for their own dinner and activities. And we're certainly looking at their pacing and their structure that we hopefully help them set up while they've been an inpatient so that they can see that they can functionally do this once they're home again.
So, Jim, you probably have the worst job of any of these folks because you get the patient at the beginning and you spend entire shifts with them. What do you see and what are you working on with people when they first come in the program?
So I guess you probably want to know why I want to work with this difficult population, but and still keep working So when I first came, I liked the idea that this program was a rehabilitation type program. Actually wasn't thrilled with the idea that, because I really never wanted to, or never had any plans to work in psychiatry. But I really liked the idea of going from having worked in surgery, doing everything for patients, to teaching them how to kind of regain some control and some measure of the life that they had before. And so rehabilitation was the key for me, and that there was a lot of teaching that we'd be doing. So, and that's really kind of stayed with me throughout the years, is that a lot of these patients come in, and in most cases, or in many cases, they're intoxicated on, as Dr. Clark mentioned, sometimes 1,000 milligrams of OxyContin or similar doses of morphine or fentanyl, or you name it. But they're often extremely sedated, and their function has pretty much gone to getting up out of bed, getting a medicine, eating something, going back to bed, and that's how kind of life is. So when they come through the door, it's a pretty scary thing for them. I think the idea that they're going to be doing physical therapy, we're going to take them off to pain medicine, and and have them be going through an 8-hour day where they weren't able to get through maybe a couple hours a day. So the first part is really helping them understand that they can do this, and many people like them are able to get through this type of program, that we won't make them so sick that we can take them gradually off of their opiates and the variety of other medicines, including benzodiazepines and muscle relaxers, and still be able to function well enough to be able to go to physical therapy or occupational therapy, to sit in classes every day. And a key component of that is that they're part of a group of people that support them, that are going through the same thing. And that support from other patients is really crucial, and that helps them both helping each other and learning together what kind of things that they can do to help themselves. As the patients kind of move through this process, they start to wake up a little bit, and either they're really excited that they're doing better on much less medicine, or they're really scared to death that they're going to get really sick and they're not going to be able to make it, or they even decide, I don't know if I want to do this, and sometimes bail out. But for the most part, we're able to help them through that process of withdrawing from medicines, and often treating an underlying depression. And so as their mood gets better, they get to be more awake, they're going to physical therapy, they got friends that are going through the same thing they're going through, and then they sort of get the idea that, maybe I can do this and I can make it. And so we have a pretty structured day. Once they get started in the program, we start the tapers, they're going to physical therapy. In the morning they have an nursing education group, which includes stress management, relaxation, coping skills, communication skills, all kinds of things that they would benefit from participating in as they, again, regain some control of their lives. And then after, usually a couple of weeks or so, they start to really take on kind of the understanding their role and really engaging in most cases. And some, it's more difficult for others, but at some point, as they've gotten off their opiates, it's not uncommon that their pain is not only better, but sometimes much better, even very low levels of pain. And at the very least, their pain is no worse, and they're functioning at a much higher level. So in that way, it's been very rewarding for me to see patients go from someone's lying in bed, intoxicated, not functioning, and depressed, and sometimes suicidal, to being able to regain control of their lives, be able to do the things that they used to do. Their family see the old person coming back as they're less intoxicated. And they get to a point where, and they move on to tracing service in the day hospital, and that's also another big transition. Now you can do this in the inpatient setting, but now can you start doing some of those things by coming into the hospital from outside? Can you get yourself here, like going to work every day? And can you start incorporating some of the things that the learned over the course of a couple of weeks. So that's kind of the summary.
Yeah, thanks. James, you want to talk a little bit about some of the aspects of the interpersonal relationships and the family work that you do and how isolated these people have become?
When these people arrive on Myers 6, this is like the last stop for the train. They have been through everything, surgeries, procedures, medications, trials of this and that, and they have gone through the gamut of treatment. And they're in a desperate spot. They're stuck. And so my job is to meet with them and their families and to seriously look at sort of two things. Look at what their wants are and also look at what their needs are, right? Because as Dr. Clark was alluding to earlier, you can have somebody who comes in for treatment who might be a customer, who has all these things that they want. They want to be cured, they want their pain to go away, they want miraculous things to occur. And what we're trying to do is, and what I'm trying to do is work with them and their families to understand that we're not going to cure them of their pain, but we're going to give them better relative control of the pain that they have so that they can learn how to manage that, regulate that, and go on to live more functional lives. So that's a very difficult process because this chronic pain that they have is exquisitely taxing to not only them, but all the members of their family, all people that they have an intimate connection with. And so we try to, as Jim was saying, this is a process of treatment. And we sort of take them one step at a time, have them focus on the step that they're working on, and then as they seem to master that, go on to the next step. So we want them to be able to have education and knowledge of what a healthy relationship looks like between themselves and maybe a family member. We want them to understand what they're capable of. A lot of what we do is really also changing what their belief system is. Because when they come in, Jim said, they're scared, they're uncertain, they don't know what's going to be coming next. This is a gamble for them. They're not sure what it's going to be like to be somebody who's not on all these pain medications. So we slowly but surely are trying to help them to learn that they can believe in themselves again. They do have capacity. They do have capacity to be able to have healthier, more normal, more functional relationships with the people that, again, they're intimately connected with.
Yeah, thanks. I mean, I think you've heard everybody talk about function and practice and skill development. The idea here is that we're not just trying to force people to live with pain. We are actually decreasing pain in a number of different ways, but one of the biggest ways is that as they live a functional life, it's amazing how much of their pain melts away and how much more satisfying life is, so that they have something else to focus on rather than the reward of being pain-free or comfortable, which is, again, one of the patterns that they've gotten into. So how many of you are using a coping skill right now? Come on, everybody is. Everybody is. But you don't think about that. Now, the fact that every one of you is here today, how many of you woke up today and said, yeah, I can't wait to get out of bed and get to work? Yeah, almost nobody. And if you're over the age of about 40, you didn't wake up pain-free, trust me. And yet, you're all here. And that didn't require a formal training process in coping skills. That is something that you've learned inherently by doing stuff, even when you didn't want to do it or feel like doing it. And hopefully at the end of the day, today, you'll say, That was a pretty good day. I'm glad I went. I'm glad I did it. And oh look, I got paid. That was good. And I have a job to go back to tomorrow. That's even better. And that makes it easier to get up the next day, and the next day, and the next day. And you know what? There's going to be some day that you wake up with a horrible migraine or a terrible upset stomach, and you're still going to come to work because of the reward that you get out of doing that. That's what we're trying to help these patients recapture. Now, you can imagine that if it hasn't dawned on you already from what I've said, that one of the ethical issues that kind of comes up before people even get to us is, what's the point? Isn't this futile? Aren't these patients that have used up so many healthcare resources and gotten no benefit that they should be cut off? They should be denied any more healthcare. They should really just either be rejected from the system because there's nothing to be done for them, or they should just be made comfortable like they want and stop costing us a bunch of money. Now, I'm guessing that you don't think that and you wouldn't subscribe to that, but insurance companies do. And we have a full-time person who should be sitting at this table who all she does is take referrals and talk to insurance companies and try to get enough clinical information from the records of all these other providers so that she can say, this person really needs to be here and would benefit from this very expensive, very intense, long service. And then the other side of that ethical dilemma is when now the patient's with us, they've been here for some period of time, and they're kind of starting to get better, but they're not really ready to leave the hospital. And the insurance company says, you know, we're not going to authorize any more days. Now what do? Do you keep the patient, and now you risk them incurring a bill? Do you fight with the hospital to say, please write that bill off? Do you fight with the insurance company and go up through the review process and the medical director and say, you know, you really got to understand this very unique program. There aren't any others like it in the country, so I understand why you don't get it, but that doesn't help my patient. Do you have the family call up their benefits coordinator at work and say, wait a second, in this instance, I am the customer, and I'm getting crummy treatment and crummy benefits from you, and I might change my insurance plan next year? Or do you have them call up the insurance commissioner of the state or their state representative and say, this is terrible treatment. This isn't health care for America. So all of those things have been done and are frequently done. But there are times when, for whatever reason, we fail that mission and the patient ends up leaving. And then we're faced with trying to figure out, well, you know, talk about moral distress. When you know that you can get somebody well and you aren't allowed to do that, that is not easy. When you get somebody through this process and you've taken them off 1,000 milligrams of OxyContin a day, and they say at discharge, I want my medicines back. What do? It's their property, right? They bought it. They paid for it. It's not mine. It's a controlled substance. Now I got to worry about how to dispose of it, how to make sure I meet the pharmacy regulations, et cetera, et cetera. But do I hand them back a loaded gun? Because, again, remember that even though it's theirs, you don't know what they're going to do with it. It's a temptation at least, and at worst it is a loaded gun because we've reset their tolerance for opioids. And now if they go back to taking what they're used to taking, they're going to kill themselves unintentionally. So I don't want to drone on forever, but I want to give you guys a chance to ask questions or to put forth issues that you think we might be missing or might be struggling with. Anybody have, you gotta have some comments. Yeah.
So I know we're focusing a lot on the
Here, use
inpatient.
the microphone.
I know we're focusing a lot on the inpatient side. But for the clinicians that are on outpatient side of the house and who are also, need to keep standards up for patient satisfaction, and you are exposed to a patient who has increasing needs for opioid medications, and you only have a very short time to work with a patient, what is the recommendation what is your recommendation to how to treat that type of patient on an outpatient setting? This is one of the very few programs around. A lot of these patients are obviously floating around everywhere. How do you recommend working with that type of patient? And the other side of the coin is with the new focus on reducing the amount of opioids that we prescribe, how do you see that working to the advantage of those types of patients?
Yeah, so that's an easy one. I can wrap this up and move on. There are people in the room that take care of these patients and prescribe these medicines, and I'm not here to say that opioids are all bad. Insulin is an incredibly risky medication to use, and has a lot of consequences of long-term use, but yet we use it. There are plenty of medications over the years that we found out are disastrous consequences, and they're off the market, or we don't prescribe them except in very heroic situations. And yet we do have an opioid epidemic, and we do have more people with opioid use disorders dying of overdoses and seeking treatment that they can't get, and switching to heroin when they can't get their prescriptions. And you have now a country that is legislating prescribing limits, writing guidelines that say that none of these medicines should be used, various lobbyist groups saying such, people asking for more access to substance abuse treatment and the funding of that. But, I'm really going to kill that phone. It's kind of like chronic pain, actually.
Yeah.
This year in the Maryland legislature, there was a bill that was proposed that would limit the prescription of any opioid to a 1-week supply. Now, can you imagine that? How likely is it that the system could even respond to that? 4 times as many prescriptions, 4 times as many co-pays, 4 times as many, pharmacy fills. Ridiculous. The same thing is true in certain states where you're only supposed to prescribe X up to 90 milligram equivalents of morphine. Well, what about that person that is laying over in oncology who needs 4 times that amount and is awake and functional? So I think that the problem here is that people do not have the kind of supports and the necessary resources with which to take care of people. And one of the problems in primary care is that there has not been enough training in chronic pain management, and people give analgesics. They give Tylenol, they give NSAIDs, they give Tramadol, they give opioids. And when you talk about what are the alternatives, it's hard to get access to these people in the outpatient world. It's hard to get people to prescribe neuropathic pain meds. It's hard to get people to prescribe antidepressants for depression. And as a result, people end up in this kind of unending vicious cycle. So we are not going to fix the opioid prescribing epidemic anytime soon, because most doctors are on the introverted side of the scale, and once we start doing something, we don't stop. And we're prescribing a lot of opioids. So we're probably not going to stop anytime soon. We might cut back, but we need help. Yeah, Jane.
As I read through
Wait for
this
the
case,
microphone.
thank you all very much for taking care of the population that can take care of. As challenging population, as we know, in patient relations. A question though, that is, I think, ethics related. If you have a patient who comes to you, like this patient as described on this piece of paper, who's had 3 significant surgeries, and I can't speak to this patient or if this is in fact a hypothetical or some composite, but some surgeries may be done by 3 different surgeons, and perhaps they are not all helpful to the problem that you're seeing a patient who's had surgical interventions that have actually adversely affected their baseline. And a patient goes in thinking, oh, this is great, surgical intervention, I'll be cured, I'll be fixed. But in fact, it makes it worse. So when you see a patient who's come to you and you think that the surgery that has already been provided was actually not beneficial or perhaps even harmed them, what is your position? What is the ethical position? How do you advise? What do you do with that?
Yeah, so we see that all the time where people are wanting more of something or searching for the Holy Grail and are willing to take what we think are unbelievable risks, and likely have already suffered or had poor outcomes. But let me ask other people on the panel, when patients kind of present you with that rationale and that scenario, what do you say to them? Anybody want to take a crack at it?
I will. So I think it's complicated, and it's complicated because patients are complicated, and their way of healing is complicated. So this is so typical. It's just as if you could read this on the neurosurgery service. It's one begets the other because of people's ability or inability to heal. And is it, what we see in this population as well, is there's so much to the personality of the person in terms of that whole healing process, being able to tolerate maybe a small amount of pain and go on with their life as opposed to having to get a fix each time. So ethically, I think, like in the arena of medication, I'll get back to the surgery. Doctors want to heal. Doctors want to help. And so they may have their own specialty in which that's how they operate. And God bless them, really. But sometimes the healing doesn't produce, the healing attempts don't produce the healing. And so then you get into more difficulty with too much medicine or too many surgeries. And then they end up with us because the doctors throw their hands up in the air and please help me, I don't know what to do anymore. And that's a bad feeling, I think, for a physician to not be able to do anything anymore in a particular regard. Now, I think we're getting better. Working here helps a lot because there's a lot of subspecialties, a lot of places where you can get advice and people can get help. But this doesn't exist everywhere, and that's why we have an issue. But I think you can't always blame people because they're trying to do the right thing. There's that occasional blame is well deserved, but that usually gets taken care of. But otherwise, I think people are in a tough spot, and patients suffer as a result, sometimes of their own regard.
Well, I think a lot of times what we're asking people to do is to not necessarily point the finger and blame something or someone, but we're asking them to think about learning from past behaviors and choices, and where are they going to direct limited resources. And if you are searching for the Holy Grail, that's a lot of resource for perhaps little return. And if you're willing to embark on a risky procedure just with the hope that someone will fix you, and that hasn't occurred, and people are telling you that's not likely to occur, that's a huge distraction and waste of resources and potential complication. And so a lot of what we're trying to do with people is to get them to appreciate that they actually do have the means within them to make progress and to be more functional and to feel better, that they don't necessarily need somebody to do that to them, particularly at such high cost. It's a hard argument for people to accept because they're suffering and they have been through a lot, and everybody hopes for the quick fix. But these are obviously, as you've heard, not quick fixes. Yeah, in the back.
I think my question goes around perhaps etiology, sort of twofold. One, I was thinking to myself, in your intake process, what is your process for reviewing the past evaluations and so forth? What's an intake evaluation from a medical, physical health perspective to be certain that there's not a lesion or something that's actually wrong that's causing pain? Because sometimes one fears pain because our bodies know that pain is supposed to tell us something bad's happening and therefore we should stop doing it. So how can we be assured that we're not missing something that's treatable otherwise, or that somehow we would exacerbate? And the other piece was, you mentioned in this case that the patient had depression with suicidal ideation, and what's the approach to treating and managing that, and kind of what really helps to make things get better?
Yeah, so these are important issues because people are coming to you after having been veterans of the healthcare system. They have more experience with us and the way things work and the tests that are available than probably any person you'll ever meet. And as a result, there is a constant push from them to do one more test or to take one more consult or whatever. You know that there is no way to disprove a negative. We don't think there's anything that we can find to fix, cure, whatever. You all know the limitations of tests and us. And so maybe somebody has missed something. You're on a psychiatry service after all. And so I'm not a neurosurgeon, and I'm not a neurologist, and I'm not a rheumatologist. But I think that one of the great strengths of this department is that psychiatry here really does see itself as a medical discipline. And we really do think that we should take care of basic problems and be aware of a scope of issues that relate to our disorder and its conditions. So we do work people up from scratch. Not completely from scratch, but we do a full H&P. We do think about what's been done and what's been ruled out and was it adequate. And sometimes we find stuff, which on the one hand is pretty funny if you're a psychiatrist and you're diagnosing a metastatic esophageal cancer, which I did, but it's pretty sad and pretty pathetic that the healthcare system checked this guy's hematocrit at age 35 or 38 for years and watched it drift down to 22 with no other hematologic problem or dietary deficiency, and yet said, well, he has chronic abdominal pain. I guess it's anemia of chronic disease, one of the terms that I hate. And people wonder, the residents ask me, why are we always working up anemias? Well, because I'm an introvert, and when something bad goes wrong, I never forget about it, and I will never forget that guy who we made the diagnosis of metastatic esophageal cancer. We've diagnosed pancreatic cancer. We've diagnosed opportunistic infections of vertebral bodies. We found brain tumors. we've got about 5 cases now of stiff person syndrome that have been diagnosed as conversion disorders and sent to us. And so it is absolutely critical that you do not just admit people to the slipstream and turn the crank and have them pop out the other end. Yes, there are themes to what we do, but there are reasons why we individualize it and take that approach. It's really critical. Other questions? Oh, the suicide. I'm sorry, I forgot your second point. The issue, really the way in which we approach patients, and some of you may have heard this if you've been at Hopkins long enough, is we really do try to organize the information of these cases around 4 disciplines or perspectives. What diseases do they have that we might potentially fix, cure, get rid of entirely, or at least manage better? Major depression, neuropathic pain, other things that I've been describing. But then we also try to incorporate 3 other domains. One is, who are we taking care of? Who's the person? What is their trait composition? Are they an introvert? Are they an extrovert? Are they smart? Are they not so smart? Do they have some trait variability in the sense that they tend to be somaticizers and very sensitive to body sensations or not? And we try to think about how that is influencing their ability to meet the demands of their life and causing distress. We also think about what behaviors are they engaged in and what kind of habitual behaviors have gotten them into trouble. And these are all high healthcare utilizers. And that is a behavior. Going to see the doctor repeatedly and taking medicines and time off from work and being functionally disabled for many folks is a behavioral disorder, which is why you heard Maggie and Tess talk about getting around the fear and getting people moving again and demonstrating to them that, look, your spine didn't break. You actually can still stand. And then the last domain really is what's going on in their life. Because all these people come to us saying, my life is a failure, I can't believe this has happened to me, what am I going to do, how am I ever going to have a productive life? Because they've meaningfully interpreted what's happened to them. And it's different for everybody. Everybody has a different story. So, again, there are themes in the program, but it's very important for me to understand why you might be so demoralized and discouraged about what your life has to hold versus someone else. And we routinely see people that are in abusive marriages and terrible home situations where it's no wonder they're sick. And it's also no wonder that they don't want to leave Myers 6, which is hard for me to believe sometimes. But you have to know those things. So that's why we try to pull all these different areas together, because otherwise we could find ourselves in a sack of, oh, that's hopeless. Yeah, there's somebody in the back?
I think you sort of answered the question. I was going to follow up on that comment, but I was wondering, there's a trend toward this trauma-informed care in healthcare environments where people coming into acute care services are recognized as having a past, that if they recognize these things like the adverse childhood experiences, scores, it's correlated not just with their mental health, but physical health. And I was curious what your impression is of whether sounds like you're focusing more on, let's not have you lay on the couch and figure out what went wrong in your childhood, but really change behaviors so that you break that loop. And if you just comment a little bit on that, figuring out why versus just changing the behavior.
Yeah, no, absolutely. And it's hard to talk about all aspects of what we do in a short period of time, because I wouldn't want you to think that we don't use medications. We do, and we think they're appropriate. We certainly are aware of the high rates of personal traumas in cases like this. Again, trauma is a life story issue because it's a meaningful event. And how people interpret events in their lives, is highly individual. And so it's important for me to understand, well, what have you been through? And it'd be easy for me to say, well, that's a trauma, and that's not a trauma, and that's not a big deal, so get over it, or that's terrible, so let's go down that road for a while. It's really about trying to engage with folks, and as you heard here, engaging with people is a very important aspect of what we do, and as you're working with them, they tell you about stuff, and you can explore things in more secure ways. And when you hear about those traumatic experiences, it helps you to then put them in a larger context and think about, is that something we can work on now, or is that something that really is best left for later when you have a longitudinal relationship with a therapist. So we certainly do want to know about all those things, and then we try to figure out what can we do about it when we find them. Other comments? We haven't, what?
I have one.
Okay, sure. Need your microphone, then.
Yeah. Oh,
There,
maybe do.
no, you just turned it on. You're
So-
a physical therapist to help us.
Yeah, I know. Any of you that have had physical therapy know how important these people are. But the additional point I'd like to make too is the incredible job of the front line for this population in terms of who spends 8 hours with them, and that's the nursing staff. And they walk a fine line in terms of setting limits and giving support and being understanding. And sometimes you have to change that hat several times a day with several different patients. And believe me, that takes its toll as well. So I think they're champions at what they do, and they really do help get patients better. The whole team helps get patients better. It is absolutely a team approach to a very difficult patient population, and it works. And many of us have worked together for many years, and we know each other very well, and we know each other's strengths and who might need help from time to time. So I don't think you can underestimate that importance.
Yeah, I would echo that. I fall down short on the self-promotion side of life, but I really do want to highlight this group of people and the program and what it accomplishes on a regular basis. And the real reason why I wanted to do this session today is to highlight for you that when you have true experts doing what they do best, that you really can work a miracle, and you really can overcome what seem to be almost impossible situations. And so I know it's easy to get discouraged. I know we work in a tough environment. I know there are frustrations around every corner, but this really is a special place with special people, and we do special things. And so I hope that in that moment when you're thinking, I can't do this anymore, or this person is driving me crazy, or I wish they'd just leave, that you step back and say, they're a sick person who is really struggling and probably don't know what else to do, but perhaps I do, and perhaps there's somebody else here who can help me do it. Thanks so much, everybody. I appreciate the time.